We are waiting for the interesting panel discussion on rational use of antibiotics. The moderator for the panel discussion is Dr. Kunal Sarkar. Dr. Sarkar is a senior cardiac surgeon and is senior vice chairman Medica Super Specialty Hospital. Sir is an avid debater since his school and college days at St. Xavier's and at Medical College, Calcutta, respectively. Shaha, sir, request you to be on stage. Dr. S.K. Todi, Dr. Raja Dhar, Dr. Bhaskar Narayan Chaudhary, and Dr. Shubhankar Chaudhary. Request you to be on stage, please, sir.
A very good afternoon to you all. First of all, a note of personal gratitude. I consider this to be a privilege that you've considered a very humble plumber to discuss something which is as profound as this. It's an extremely laudable initiative from everybody, from Justice Banerjee. It's a privilege to see Professor Mukherjee with us in the afternoon, who's just been recovering from a bout of chest infection himself. Now, there are a few important prerequisites of a good panel discussion. The first one is that you should have members of a panel who are very, very well enlightened on the subject and a moderator who almost knows nothing. So both those two conditions, I think, have been amply met. And let's move on. I believe we are in a bit of rush for time. So what I'll do is I'll throw out a few questions which has been very intensely tutored by Dr. Tanmoy Banerjee. And if you find the questions to be inappropriate, it's entirely his fault. Right. So we will, I think let's stick to about 3 to 4 minutes each, your reaction to the first round. And after which I think we will spend a few minutes for your supplementary remarks and perhaps have a little bit of time to take a few questions from the audience. You see, my proximity, apart from almost 3 decades in cardiac surgery, to antibiotics has been, I used to work in the next block to the room where on 28th of September 1928, a Scotsman who came back from a week's holiday, by leaving a window open, just looked back on his shelf and found the inhibition around the spores of bacteria, because Alexander Fleming's room, where he used to work, was exactly a block away from our cardiac surgery department. And as a great note of respect to Fleming, that window was very seldom closed unless they had lashing rain, because that open window made an entire difference, an enormous impact on the future of medicine. Alexander Fleming was a very interesting character. He actually wanted to be a surgeon. And you see, great things happen if you don't allow people to become surgeons. I just did not know of it in good time. If I did, I would have definitely mended my ways. A very active man, and he died suddenly of a coronary arrest. He literally died when he was working in his lab, and he had a cardiac arrest, a frank coronary attack, and he had it a year before even coronary angiograms were being done. Right, so with that little anecdote, I think you know all of us, all the members in the panel. Can I ask Raja, Dr. Raja Dhar? Raja, we are talking here about an antibiotic stewardship program. We are talking about antibiotic policies. And you, with your experience, it's good to see a lot of young people in the audience. Just simplify the concept to them, that is it something to facilitate rational practice, patients benefit, or we are just being very overpowering on everybody who has the authority to prescribe antibiotics? What is the basic concept of the stewardship program?
So thank you, Kunalda, and pleasure to be a part of this elite panel. So I think antibiotic stewardship programs are very important, and I don't need to say this to this audience. I think you've heard this before. But the more important question that Kunalda is asking is, why is it important? So Professor Mukherjee just asked about audit of antibiotics in a hospital. So the reason he's asking about audits or other people are asking about audits is to find out what is the sort of antibiotic that we are prescribing against the bugs that are growing in a particular intensive care unit or in the entire hospital. That's the question that you're asking. So if you know what sort of bugs, what sort of antibiotics, and then you have a justification for prescription if you're going outside the mandate antibiotics, you have a protocol which people can follow in the long term. So stewardship is important for more than one reason. First is you know your local microbiology, the microbiome of your particular unit or of your particular hospital. Second, you know whether people are prescribing antibiotics which cover the bugs that are growing in that particular unit or in the hospital. Third, the resistance pattern in that particular unit and whether the antibiotics that you're prescribing on an audit cover the resistant bugs that you're giving. And fourth, whether you're actually overprescribing antibiotics and running out the reserve antibiotics. Whether you are actually running out of the reserve antibiotics. We had this question a little while ago about a lot of carbapenem resistant bugs in the intensive care unit. I think the question stems from there. If you go on to prescribe a polymyxin antibiotic to everyone or a combination of something like an aztreonam and a ceftazidime avibactam to overcome carbapenem resistance, then your antibiotic stewardship program would go for a toss. So I think Bhaskar can probably add to that.
Yeah, we will get to it. Rather, just a quick question. You see, since you are in the domain of respiratory chest medicine, we actually grew up in an era when I think all these antibiograms were a bit hard to come by. And what used to happen is we had some very convenient formulation, some drug once a day going on for 7 days, a lot of knee-jerk prescriptions. Do you, in your practice, now see that trend has decreased? Has it decreased or not really?
So I think antibiotic prescriptions have gone up, Kunal. I think the number of people who get prescribed antibiotics are even more than before. And I think I'll go back to the talk that Bibhutita gave a little while ago. So I think there are both sides of the story. So the youngster with 2 days of fever, with a bit of myalgia, body ache, would be an inappropriate candidate for an antibiotic, but would get an antibiotic in most cases, that too over the phone in most cases, or over the counter. So that's one end of the spectrum. The other end of the spectrum is the second patient he presented, which was a 68-year-old gentleman who's got diabetes, multiple comorbidities, comes in with a high fever, and there the rational use of antibiotics would mandate actually early prescription of antibiotics with all the investigations that he spoke about. So it's not to sacrifice the culture, the inflammatory markers, the chest X-ray and so on, but to do them, but to start the empiric antibiotics and then wait for the results to come back. So it has to be a balance. It cannot be no antibiotics, just wait till you get reports back. On the other side, it cannot be knee-jerk reaction like you put it, 7 days of maybe a levofloxacin or a course of azithromycin for everyone like happened during the COVID times.
Correct. Thanks, Raja. Dr. Shaha, I think perhaps two facets we would like to know from you, because Raja has already kicked off mentioning the place, the rationality of an antibiotic stewardship program. Implementing that in a government hospital, in a teaching hospital, would that be easier or would that be more difficult? First question. And second question is that, look, ever since even we were in Sir's ward in medical college, we are trying to rationalize this practice, and we should continue to do so. But this limitless invasion of brands and, the non-generic brand-based practice, God knows why and for what rationality is it allowed in India. It does not happen anywhere else in the world. And thereby, I think every brand of a popular antibiotic probably has 50% sales across the counter. Doesn't even need a prescription. So how do we reconcile to this reality? We are discussing sincerely about rationalizing hospital medicine, but we have two other issues. One is a limitless, mindless proliferation of companies and brands. And the third thing is, this invariably brings in a very vicarious practice, which is across the counter. You can probably, the only thing that we do not dispense across the counter is a nuclear bomb in India. Other than that, everything is available without a prescription. Dr. Shah.
So, you have raised a very pertinent issue. This is happening everywhere, rampantly. Now,
but mind you, this is a very Indian situation.
Yeah, of course.
Very Indian situation.
Of course, yeah. So, there are many perspectives of this. One is the perspective of the public. If I ask a general man earning 15,000 rupees a month, having 2 kids at home, he gets a fever, 3-4 days, cough. If he goes to a local physician, the fees can be anything around, how much, 300, 400, general practitioners. And then he prescribes a course of medicine, will of course include an antibiotic, obviously. So he purchases that and so adds up to the cost. So he chooses easier, and if he is to go to a hospital, standing in the queue, he has to waste the whole day to go to the doctor, get the prescription, then go to the pharmacy, get the medicine. Medicine may not be there always, though most of the time, fortunately, we have good supply of medicine in the government hospital. So you have to compare the two things. So, and he's not very concerned. Also, he's also thinking that maybe it's not that serious. So let me go to the counter, have some medicines, and if it doesn't work, then maybe after 2-3 days I'll go to a doctor and the things. So it is from their perspective. Now, if you look at the authorities' perspective, you have very rightly mentioned that newer companies coming up, and when the things are going off patent, the price is, when it's patented, the price is very high. All the medicines, when they're patented, the price is very high. Once it's off patent, many brands are coming up. Quality, we are not very sure. And if you look at the people who are supposed to look at the quality of the medicines being produced, I'm not quite sure whether that's being looked after properly or not. So, now if you look at our perspective, as you said, and because this seminar, workshop is about, and also various such workshops are being held everywhere, the main purpose is to do some justice. But we are not being able to do bring any rational practice. If you look at the hospital, if I ask you to look at a prescription of any hospital, if you go to, I have seen many prescriptions of many government hospitals from various specialties. Many times, unfortunately, I could not find a logic in the prescription. Then I think it's we, senior people, who have not been able to inculcate the practice of doing justified, rational prescription of antibiotics. So this has to be given looked into very seriously in the medical curriculum of all the courses, and also I think all the IMAs, API, everything, everywhere. I think this has to be taken very seriously. The message has to go everywhere, and some sort of audit at least. Whether, I don't know whether, I heard in the news some time ago that one shop in a hospital, near a big specialty hospital in Kolkata was raided by people of the government hospital, and they seized some prescriptions, and those doctors are called, and why were they writing branded medicines? Though the directive from the government was to write generics. It's also from the NMC also, but many of us not following that. So, regulations has to be there properly. I think so, to summarize my answer, we need to give this very serious thought during the medical training courses, number one. Regular medical education programs has to be done. Auditing of the prescriptions as much as way as possible has to be done. And government and the concerned authorities have to look at very seriously about the practice of dispensing medicines by the chemist shop. This has to be stopped. But at the same time, healthcare has to be more affordable so that the man does not have to waste his wage to go to a hospital, get the medicine. So we need to find out some way so that someone can get to a reliable health facility, and in some reasonable time, he can get a prescription, rational prescription, get the drug, and go back to his job maybe another 3-4 hours. So that is something we need to do also. This may be my way of looking at the problem.
You see, in our very busy government hospitals, who are already under severe pressure from the volumes of patients they see every day, has this system already started? This having an antibiotic policy for a hospital in an area, what Raja was referring to. Do we have a policy, or has the thought process started in the big, I mean, in the enormous government hospitals with their patient load? It's nothing like what we see in private sector.
Yeah, you are very right in pointing that out. I think the private hospitals had been pioneer in, I know few of the hospitals. Subhash's hospital has done a good job, I know, because I was associated with them. In government hospitals, most of the hospitals, this has either started or they're already way to it. Some has put up, and in some hospitals, some of the units have their own antibiotic policies, though that may not be the whole hospital's antibiotic policy, but they are giving very serious thought about this. So, and NMC has made a mandate also. National Medical Commission has also made a mandate that every hospital should have an antibiotic policy which has to be communicated to them. So that's a good step, very good step that National Medical Commission has done. So I think this will push all the government hospitals also to have this, so that, and for the betterment of the people.
Thank you, Dr. Shah. Shubhankar, the two sort of inputs we are keen to hear from you. One is, I'm just personally curious, because there is such a lot of bizarre numbers floating in the air, that what do you consider to be the incidence of diabetes in the adult population? Because rumor has it that very shortly, unless you are diabetic, they will deny you an Indian Aadhaar card or something like that. That's number one. That what is a diabetologist? Bizarre figures are going around everywhere. Secondly is, with this number of population and diabetes load, does diabetes influence or cloud the rational antibiotic prescription vis-a-vis the outpatients department? Because you have a tremendous load of outpatients traffic, with you.
Right. Thanks. Can I, again, maybe go back and talk about, maybe stress about unique needs? I mean, you did mention about so many brands being available, which is not available elsewhere in the world. I do not necessarily support that, but what I wish to say is, one of my very close friends whom you know, who went off to England soon after we did our post-graduation, a very close friend of mine, and the first experience he came back with is that he said, I was on a night call and we had a lady with a breast abscess and I did the job very well, and next day the consultant comes and then after having done the job, you should pencil in whatever, six hourly, whatever I had written. So the consultant next day comes and asks me, so were you not very sure of your drainage of the abscess? He said, no, it was absolutely fine. And then he asks, then why did you prescribe the antibiotic? So here, I don't know whether what pertains in England will also be true here, whether we should or should not pre-operatively or post-operatively, whether should prescribe antibiotics. That may depend also on your milieu. So we cannot always just extrapolate from what maybe England or US has done. I mean, just a basic opener. About the prevalence of diabetes, I mean, I myself do not know the exact figures, but we were part of the ICMR in-diab study conducted in different parts of the country, and I was in charge of the portion being done in West Bengal. Here, the prevalence was roughly about 15%, with rural being a bit lower, urban being a bit higher, but not a whole lot different of the adult population. So that's number one. The second question is also very relevant, where we say that we should hold back on antibiotics because this could just be a viral infection. Why use an antibiotic? But on the other hand, as Raja said, that if you have an elderly person with comorbidities, then maybe we are wasting useful time. So diabetes is one condition where infections can take a more severe form. So yes, I think there should be a provision to consider what is the background and then decide whether 3 days or 4 days fever should merit an empiric treatment of antibiotic, of course after sending relevant whatever materials. There also, of course, is a problem. If you send more materials, then of course you are accused that you are in collusion with the lab, you are sending unnecessary tests. Those are also issues that can come up at a general practice level. So those have also got to be looked at from the higher people in the authority. So these physicians also have proper protection when they're advising proper tests. So yes, having diabetes should qualify for a lower threshold for use of antibiotics, and in choice of antibiotics, probably a preference for bacteriolytic rather than bacteriostatic antibiotics could be a general statement.
Do you see a lower threshold for prescribing investigations as well?
Yes, sure.
You do.
Sure.
You do.
Yeah.
And any comments on, I think what Shuvasda was referring to earlier, that we need separate kind of guidelines in separate, like the OPD based. I mean, how would you react to that? That it's difficult to cover with a blanket statement?
Yeah, that's a problem, but we should be having, I'm sure, I mean, it stands to reason. I mean, antibiotic policy for the intensive care unit will be different from one in the OPD. Yeah, sure.
Fair enough. Suvashta, you see, critical care, right? I think the heat is on. It's a bit of a hit and run situation. Obviously, no healthy person ever comes to a hospital, and no one, unless very, very, very sick, ever makes their way to the critical care. So serious disease, limited time, financial stakes are also high. How does that boiling pot of a situation influence your clinical approach and antibiotic usage?
You know, there's no gold standard for diagnosing infection. We still do not have. So, and that's why this overuse of antibiotics. There's no gold standard. Nobody knows the fever is viral or bacterial. There's no definite. So, most of the patients who are very sick do get empirical antibiotic when they are very sick and come to the ICU. Question, there are two things, rapid diagnostics and can we decrease, find out is it pancreatitis, is it infection, is it MI, and then decrease the use of antibiotics. And decrease, I think the back end is the most important. It's very difficult not to give antibiotic to a very sick patient, but the duration, that is where the thirst is now. You know, there was a custom of giving 10 days, 14 days, it came down to 7 days, now it's 5 days. In post-op peritonitis, they say if source is controlled, and as Shubhankar said, you have drained the abscess, why antibiotic? And that is where we are missing. We probably give too much, too long an antibiotic. And that's where I think we know the problem. Question is solution. What are the solutions we can get? I think decreasing the duration of antibiotic. The question which is raised by many of the colleagues that these are all duration done in countries where they do not have MDR organism. Can I do the same with my Acinetobacter, with my Pseudomonas, with my Klebsiella? Can it cut it down to 5 days? We don't have studies. Research is something we don't have in our country. So whenever we make a statement for our country, it's not evidence-based, it's just empirical, experience-based. So that's one of the biggest lacuna we have. Unless we have a study of 7 days antibiotic in Acinetobacter versus 14 days, which they have done for in Western countries for Pseudomonas, for pneumococcal, and that's how they have decreased it. So we have our bugs. It's chicken and egg. You can't, you know, now we are there. We have our bugs. We can't get rid of them. So now we have to know how shorter duration of antibiotic will help. So I think we require more research. And as sir had said, we do audit our antibiotic use in ICU. Like for example, I will give you last 3 months, we have hardly used colistin. So we were very happy. We hardly used colistin. Then I said, show me how much ceftaz heavy had gone up. Ceftaz heavy had gone up with the same proportion. So I have not reduced my antibiotic use. I have just squeezed the balloon. And that is where we need to decrease the antibiotic burden. So even audit, we have to be sure that we are not just squeezing the balloon. Are we really decreasing the antibiotic use? And you know the outcome, whether it is decreasing the resistance pattern in my ICU or not, that is also very important. So kind of multifactorial, you know.
I'm just perhaps seeking your opinion also. We had a similar situation. Not very long ago, we did somebody with a very nasty aortic endocarditis. And when we were looking back, that what are the current recommendations, that fair enough, you go in there, chop, valve is out, replace a valve. That is a easy and relatively straightforward part of it. Now, how long do you continue antibiotics? You will obtain some isolates, etc. I was absolutely, bewildered that there are n number of. We are talking about our hospitals, our state, our cities, and all these things. Even in the academic domain, in very sticky wicket situations like that, the jury is still out. There is.
Endocarditis and all are very specific situations. But in general, I will give you an example. When we talk about solutions, how it can help. What I have seen, even in cardiac surgery, pacemakers and all, use of MRSA coverage, linezolid, vancomycin. They are very afraid. That they are rightly afraid because of infection control issues are a big problem. Our sterilization procedures are a big problem. So surgeons and doctors are afraid my patient is going to get an MRSA infection. So I need to cover with prophylaxis.
Can I take a 1 minute response from you and Raja both?
Yeah.
We've perhaps seen, covered most of our quantity of critical care exposure during the COVID times, right? What did that wartime experience teach us regarding antibiotic usage?
Initial COVID period, antibiotic use
any take-home
increased.
messages, any departures from what we were doing before? I think just give us a 1 minute.
Antibiotic stewardship, there was no steward. Everybody was getting antibiotics when they entered in the first wave. After that, people get kind of more restrained and less antibiotic in the later period.
So I think be it during COVID or be it outside COVID, Kunalda, the prescription of antibiotics in the ICU is something which is going to happen and is happening. The more pertinent question is, what do you do about trying to curtail the duration, as Subhashda said? And I think there are few things which we have not spoken about which are important, which is how good or bad is your patient, what's the graph of the patient, what's happening to the inflammatory markers, judicious use of a marker like a procalcitonin maybe 3, 4, 5 days down the line to see whether you're actually rock bottom or not and you're over treating someone with antibiotics. So I think shortening the duration is important. I think it's any ICU in the world, there would be very few people who would not treat someone with a perceived infection and wait to see whether this is pancreatitis or whether this is infection. The thing you would probably do is to take off the antibiotic early if you found that you're prescribing something different. One line about your COVID question. I think what we found during COVID, especially during the first wave, like Shubhasdar said, was that we did not know what the enemy was. And we thought more than COVID, it was secondary infections which was the enemy. And we created a lot of resistant bugs at the time. Our data at Fortis initially and then at CMRI showed that the number of Acinetobacter, like Bhaskarda said, had gone through the roof, especially during the first wave, because of the number of polymyxins, etc., that we have prescribed at the time. But then rationality increased, things got better from 2022 beginning, and I think the resistance profile is similar to before.
The second wave, that time.
So end of the second wave, beginning of the third, so the Omicron time, I think rationality came back. I think August, September 2021 was the time till when we were all over the place with our antibiotic prescriptions. I think post that probably things got better. We understood Omicron was not the threat that the Delta or the Alpha or the Beta was, and things got better.
Any comments, Dr. Shaha, on this?
Kunal, just one point I wanted to make. You know, I was telling you about this MRSA coverage and how to reduce the MRSA coverage and how to reduce over prescription of ceftazidime and colistin. Italy and Spain have this, Greece have the same problem. Lot of NDMs in Italy, Greece, same as we are having. What are they doing? So when their infectious disease experts come, we ask them, what do you guys do? You see, now as Shubhankar mentioned, there are open PCR system. If a patient is not carrying MEK gene, his nasal swab, he does not need an MRSA cover perioperatively. Final.
Right.
So that is done in 3,000 rupees, right? So that is one technique. Rapid diagnostics, how it can impact antibiotic prescription. 99% negative predictive value. You have to have a carriage of MEK gene. You do a rectal swab. There is no NDM in the rectal swab. You cannot get infected with NDM in pneumonia or bloodstream infection. You do not have to give colistin. So those are the things that we need to utilize. That's what they are doing. They say, no, we don't give colistin. We have a lot of NDMs, but we do rectal swab of my patient.
Good point, very good point. Dr. Chaudhary, I think perhaps the situation is more kind of synergistic and less competitive right now between the lab and the clinical domain. How strict do you think we should be having a lab validation for antibiotic prescriptions? Especially, how do we tackle in hospitals like yourself and many of us, especially government hospital, escalation of antibiotics based on lab evidence? How realistic is it in our situation? How often is it happening?
Okay, actually I can share my data. As sir was asking whether we are doing the antibiotic audits, we are doing it every month based on a particular number of audits, number of patients we are auditing, mainly the severe patients who were on antibiotic therapy from day one, from the admission in the ward. So from that we are calculating the escalation, de-escalation, change of antibiotics and those rates. And I'm finding that at least in our hospital, the de-escalation rate is more than escalation rate. But we do have some cases of escalation also where the narrow spectrum antibiotic was started. Actually, when the patients land up in the hospital, the patients are landing up from community, they may be having a community infection, community acquired infection, and the patient is very serious. Okay. So you have the markers, everything done, and a blood culture is immediately sent. So, but in many cases we find that this is a pure community acquired pneumococcus or MSSA or a pan-sensitive Klebsiella. On retrospective analysis we have found that pan-sensitive Klebsiella or some other organisms like meningococcus, which is very rare, but pneumococcus we are getting. But these kill the patients rapidly. If they land up in the intensive care unit, you will lose the patient very rapidly if the patient is not instituted on the appropriate antibiotic therapy. So if this patient is getting vancomycin and ceftriaxone and say others like colistin or meropenem, the bug may not be covered by that. MSSA doesn't respond very well to vancomycin. So flucloxacillin or at least a cephalosporin should be started in this patient for the best outcome. So actually the dictum is that whenever severe patient you are sending lactate and other markers, you are sending the blood culture and all those things, and you immediately start the patient on broad spectrum antibiotics, which include gram positive, gram negative particularly because gram negatives are more common in our country. Gram negative, gram positive, and antifungal is not warranted at this point of time. But this choice of antibiotic should be very specific depending on the diagnosis, the clinical diagnosis of the patient, which is of utmost importance. We have the labs, we have the parameters, we have the tests, everything. But what is now lacking in some of the juniors, particularly I've seen that they don't have the clinical eye to diagnose the case. Say the patient didn't have any antibiotic exposure in the last 2 or 3 months, patient has landed up in the emergency with severe pneumonia. So the first thing that will come into our mind will be pneumococcus or a pan-sensitive organism. So there we have to give the community coverage by the best antibiotic combination that is possible. Then we will send out the test. We have the BioFire pneumonia panel and all those things which can diagnose within 2 hours or 3 hours. We can give out a report. So after that, they can accordingly decide. But the best antibiotic should be given appropriately at the quickest possible time. So that is now somewhat lacking. They are getting vancomycin, they are getting ticoplanin or some other, but not getting penicillin or not getting ceftriaxone. Okay. So which is the, actually should be given to some of these patients. And on the other hand, we have patients with comorbidities who have had antibiotic exposure, who are landing up in the emergency, going to the intensive care unit. There we have to give the MRSA coverage and broadest spectrum antibiotics. I have told you that in 1 or 2 cases we have been, the empirical choice was started with ceftazidime, ibactam and aztreonam because otherwise we have lost the patient. So I think
I think these are a couple of very, very critical issues you've raised. Any comments on the issues raised? Shubhankar, the Raja, you wanted to make a point? Yes.
So I just wanted to say, instead of continuation with what you said, Kunal, I think everything that Bhaskar says makes a lot of sense. But along with that, we've got a lot of young clinicians here. You know, all you need to do is to pick up the phone and speak to your colleague microbiologist and find out what is it is that you would want to prescribe in an empiric scenario. So it's, like you said, working together synergistically rather than being a clinician versus a microbiologist trying to keep the antibiotic regime precise.
Yeah, yeah. Very true. Dr. Shah, any comments on this?
I would respond to earlier question you put to me regarding the COVID and use of bacteria. So one thing was also there, many antibiotics were used, erythromycin, doxycycline, all those, as presumably as antiviral. Another thing was also there that patients were getting steroids. No hypoxia, fever, 3-4 days getting steroids. This also contributed to the development of so many bacteria, and of course mucormycosis all know about. So use of unnecessary use of steroids also has contributed to the so many of bacteria being shown in them. So that was my comment.
Very, very valid points. We will shortly throw the panel to the questions. Anything from what we have discussed so far or any adjunctive comments you would like to make? Quickly, Shubhankar, starting with you.
We hear a lot about misuse of antibiotics, and we as physicians, clinicians are pointed fingers at. I think as a society, as a government also, there is a lot of responsibility to ensure, to develop evidence-based guidelines and ensure that those are followed. So it's not just the practicing physician in his clinic who is to be blamed.
I agree. You know, this invasion of the brands, mindless invasion of multiplicity of brands has to be stopped somewhere. Any comment before?
Sorry, is anyone ready for a small story? Well, it's a quick one. Yeah. So once Shah Rukh Khan was asked, why do you promote some cigarette brand on TV?
This is pre-Pathan or post-Pathan?
No, far away, far before. So he said, don't you know this is bad for health? You are harming so many people. So he said, well, I do it because I earn money out of it. And if really the government thinks that this is bad for health, people's health, then they should ban the tobacco industry. They should stop the production of tobacco. Have they done it? No, because that's also the major revenue earner. So I mean, we are all in the same boat.
Exactly, exactly. Any other comments before we go to question quickly?
You know, we blame generics, but our generics are being sold in so many countries and very well accepted. You know, generics, nobody has evaluated them. We have very good, there are good generics and bad generics, right? So, you know, like good big pharma industry do produce good generics, they are less costly. So I think we do require some studies on that. I did once, I told I gave her 5 vials, taking all the names out. Only I knew which vial contained which antibiotic. One was patented, the another 4 were generics. And I asked them, you put a disc on that microbiology culture and tell me which one was most potent. What was the result, you think? 1 was patented, 4 were generic. She didn't know which one, only I knew. And she did a microbroth, there was a growth, and she put all the discs. Bhaskar, what do you think?
Your guess, quickly.
No, I think they will be similar.
Similar, quite right. They were all the same. So the killing of the bugs were the same.
I think, we've completed a round of discussion. We cannot but, since Sir is with us, have a brief comment from Sir. If Tanmoy wants to add something, and then we'll get ready for a couple of questions. I think, perhaps we will wind up by 5 o'clock.
I have been listening with rapt attention to all the speakers. I have got a problem. 48 hours back, I had a teleconsultation. A 56 years old lady who was a diabetic, uncontrolled, with HbA1c 10.5.
56.
Blood sugar is 400 and plus. Admitted with unconsciousness. And it was a hyperosmolar coma. She recovered from that. She had a renal failure. She was dialyzed. But consciousness never came back. Patient was febrile. No convulsion. And CT scan was done. CT scan was negative. And patient was put on ventilator. Then I had to suggest a lumbar puncture. Lumbar puncture came out, CSF protein, a CSF cell, more than 250. And CSF protein is around 190. And sugar is around 35 or 36, I forget, because I have not seen the patient. So my suggestion whether it is a case of meningitis, causing the worsening of the diabetes, renal failure, hyperosmolar coma. CSF grew nothing. And patient had been treated. I suggested for vancomycin and ceftriaxone as the initial choice of antibiotics without any microbiological report. Microbiological culture is negative. Now we are landed up with the question number 1, what is the cause of this meningitis? Number 2, could it be a case of tuberculosis? And number 3, could it be a case of fungal meningitis? How to sort it out?
Suvasta, you take it.
You know, this multiplex PCR are very, very good rapid diagnostic tools. Yes. So, this PCR should tell us for sure whether there is bacteria, whether there is virus, or there is fungus. If this PCR is negative in this patient, then I would definitely treat her for tuberculosis. If PCR is positive, then I know what is the bug and treat accordingly. So I think that is the demarcation nowadays. No, BioFire is there.
No,
they
BioFire.
give a report in, they should give a report in 6 hours.
No, BioFire, actually PCR, regarding PCR, that BioFire is very expensive, but there is multiplex PCR available on open platform also. We are considering that also to reduce the cost. So it's available, I think, around 1/4 the cost of BioFire, what BioFire costs, but we can give the report rapidly. So in this case, the CSF, the fresh CSF sample, you do not refrigerate the CSF. I find many of the consultants, they are refrigerating the CSF, looking at the clinical response, and on the second day they are sending the PCR when the patient is not responding, then the CSF sample is sent for PCR. So it will not pick up anything because the viruses are die very rapidly, even if they are kept at 2 to 8 degrees Celsius. So immediately fresh CSF you have to send for two things. One is Gene Expert, that is for TB, or any other TB or TrueNat for TB, and BioFire. So that BioFire or Gene Expert will pick up something in this patient. So accordingly you can treat it. Okay. So this is.
So what was the differential count of the cells? I mean 250 cells, and what was the differential count? CSF? Or neutrophilic? CSF টা ডিফারেনশিয়াল কাউন্ট স্যার কিরকম ছিল, মানে 250 সেলস বলেছেন
না, সেটা করা হয়নি কারণ
না
এখন সিএসএফ, এখন পেশেন্ট ইজ actually unconscious and bill is piling up because of series of antibiotics. PCR test could not be done, shortage of time, it will take time. But question remains, how do you clinically judge? Chest X-ray is normal, whether it is a case of tuberculosis or it is a case of fungal infection, that remains a vexed question in the clinical setting. I know that PCR will settle the issue, but it's not always available in that circumstances.
Sir, but you can have a India-ink preparation. India-ink preparation can show you whether Cryptococcus is present
Yes.
or not. So that is can be easily done. So in
Yes.
this case, I think that could have been done, and as he said, the Gene Expert is possible. So CSF cell count, whenever some cell count is told to us, we need to know the differential also.
And
So
even
that
after
also-
3 to 4 days of Banco and Ceftriaxone, there is no response of consciousness. That is a very important clinical pointer. Probably we are not in the right track. We are
So
not
should-
in the right track.
So we should repeat the CSF, do the tests which have not been done, including the India-ink preparation, and if BioFire is possible, then that will help us, and also Gene Expert, that will help us, sir.
And another thing I will tell you, because I got heard about an interesting case. I think I'm audible. Okay, so actually this patient had a picture like this, like fungal meningitis or tuberculous meningitis, but patient was not responding to antibiotics, not even to ATD. So I think the patient, the wet film is also important, the CSF. You have to examine the CSF when the pathologist is examining the CSF for doing the cell type, cell count and those things. The wet film should also be examined, and this patient, acanthamoeba cysts were picked up because the patient used a contact lens, and from there it has entered, and then it caused meningitis. Okay. So acanthamoeba is also a possibility where you have to treat with amphotericin B or some
Yeah, it is. Tanmay, any comments from you before we take a couple of questions, please?
First of all, sir, I'd like to say that it's been a very good discussion, fascinating, and I will thank all the panelists for that. I would like to say, like we have been all discussing about spreading more awareness of rationalization of antibiotic prescription. But how do we actually take this to the periphery, this to the doctors working in the periphery and to the general public? How we do in practice? If I can ask that question to the panelists. So because is it the government, societies or the medical fraternity, we have a responsibility. Is it going to be a government guideline? Is it going to be some kind of judiciary, or is it going to be some kind of society guideline that will help us to achieve this target?
As a physician, I think we should first try to do this, as I said during my presentation also, the CME is organized by the IMAs. So that's right, because we have very big IMA of branches everywhere, so we can do that for physicians, we can do that. And for the, there has to be some guidance from the ministry also regarding the inappropriate use of antibiotics and all those things, auditing. But we, as physicians, we can do as many CMEs as possible to the IMAs, because they have passed maybe 10, 15, 20 years ago, and they are little away from the updates. So IMAs can organize CMEs on this. That's one part of it.
And let's not forget, 60% of the prescription are by non-qualified people when you reach out. So they are probably not within the bandwidth of your IMA. Raja, yes?
Yes, so just one word. So, Tani, the other thing is that I think rather than talking about prescribing a molecule, like Vibhutida was saying a little while ago, I think it's more important to try and ration prescription of antibiotics even as an outpatient. Unless you stop OTC prescription of antibiotics, I mean, a coamoxiclav probably gets sold as much as a paracetamol does in this country, or an azithromycin gets prescribed as much as a paracetamol does in this country, and a large percentage would be OTC prescriptions. You know, so if you have a small list of antibiotics, if at all, which can be prescribed by a physician, a GP, etc., and antibiotics sold without prescription is something that's not banned, unless there is a legal structure to it, which is protects the patients from doctors prescribing the antibiotics injudiciously for outpatients. We are never going to stop the problem, however much the education, because it's easy for a doctor to write an antibiotic in a rural sector, in a suburban sector. You know, it's not difficult. Rather than saying, okay, I'll wait, in which case probably the patient will go to another doctor who will write the antibiotic for the guy. Sure. You're never going to actually get to the bottom of this.
Are there any questions? We'll take a couple of questions.
Sir, I have a question, sir. Sir, it's from different perspectives. So we are discussing about the antibiotic resistance due to our health workers and other use. But another part is there, that in animal husbandry, our country is using lots of antibiotic and much more than we use in our health, for our health. Basically, the use of antibiotic in animal husbandry causing the AMR mostly. And Sweden is the first country who stopped this, control this use in animal husbandry. We will find very
We get
funny.
the point. We get the point.
Yes,
so
sir.
what
Sir,
do you suggest?
Should we think about, should we physicians think about this and to stop or to ask government for another guideline? Like Chennai Declaration was there. Should we think of these things?
Perhaps we should. You know, it makes sense.
I was part of Chennai Declaration. Because of that, colistin has been banned in India in veterinary use. So I think that was the process, but it has not gone much far.
Right.
We had a lot of recommendations.
It's not gone far away, but sir, it's stopped only there only after discussion there.
Good point. Any other questions from the audience? I think we've yes, you have. Quick. You'll be audible. Yeah, come on. Yeah, quick.
Sir, regarding in vivo in vitro, sir, I'm asking two clinical scenarios. One is like for a 52 years old female who is suffering from gynecological malignancy and having some Klebsiella both in urine and blood. And empirically, we have started peptides. On day 5, the patient is clinically improving, his parameters are improving, his TLC, CRP is normal. Now what we have got the bug Klebsiella which is resistant to peptides and meropenem, but patient is clinically improving. Scenario 1, what you should do. Second is, sir, one patient who is clinically deteriorating and we have got the bug Klebsiella and the bug is showing sensitivity to a particular antibiotic. Like we have got Klebsiella which is sensitive to meropenem, but still the patient is clinically deteriorating. We are having the bug, we are having the sensitivity pattern, we have used the drug. In spite of that, patient is clinically deteriorating and we have excluded almost all the other possible causes which may be the possible.
We get your point.
Yes.
Would you respond, Dr. Chaudhary, to this?
Yes, I think if you see that the antibiotics is working in the patient, you treat the patient, you are not treating the report. So if the antibiotic is working, you continue that antibiotic. But on the other hand, I will tell that the BLBLI show inoculum effect. Okay, so even if they are found sensitive on in vitro susceptibility, where we are using an inoculum around 10 to the power 5, if the organism is present in higher inoculum in the tissues or in the fluids, then the MIC goes up very high. So it will not work in that case. And another question you were asking about meropenem being found sensitive. So we have found that even meropenem or carbapenems, there is some difference between meropenem, imipenem, and ertapenem MICs. We often get that meropenem, imipenem sensitive, ertapenem is resistant. That may occur in MC or ESBL hyperproduction. Okay, so you have to use the carbapenems, the group 2 carbapenems in that case. But in carbapenem sensitive organisms, we have found that the carbapenems gene has been detected by PCR. Even carbapenem, when it is showing an MIC as low as 0.03, the carbapenems production may be there. So in that case, if you are using only carbapenem monotherapy, then there may be therapeutic failure. You have to combine. So this PCR study is also very important.
I think thank you very much. We are beyond 5 o'clock. Perhaps there is some more programs on the agenda. All good things will come to an end, and so much this panel discussion this evening. Thank you all for giving us company, participating in the discussion. Thanks to all the panelists. Thank you.
Thank you very much.
Thank you, sir.
Thank you, sirs. I would just like to call upon Dr. Pranab Kumar Das to felicitate Dr. Kunal Sarkar, Dr. Raja Dhar, and Dr. Shubhankar Chaudhary, please, with a small token of appreciation. Sir. Dr. Kunal Sarkar, Dr. Raja Dhar, Dr. Shubhankar Chaudhary. Thank you, sirs. With this, we come to the end of today's session. Thank you all for your patient hearing.